We explained the pathophysiology and clinical presentation of central nervous system infections. Now, given a patient with suspected meningitis, let's recommend guideline-concordant empiric treatment. IV antibiotics should be started within 1 hour of presentation if bacterial meningitis is suspected. Antibiotics with insufficient penetration into CNS should be avoided. Those include piperacillin tazobactam, specifically because the tazobactam part does not penetrate the CSF. Amoxicillin clavulinate, again, clavulinate component will not penetrate into the CSF. Aminoglycosides in general have poor penetration to the CNS, so they should not be used as monotherapy, but they can be used in combination with other antibiotics because of synergy. Clindamycin has poor penetration. Colistin is only useful for the infections in the urine, and the same is true for nitrofurantoin. And of course, vancomycin is not absorbed and should be avoided for any systemic infection. Now, select antibiotics based on suspected pathogens empirically. And if viral meningitis or encephalitis has not been ruled out, empiric IV acyclovir should also be added to empiric antibiotics until a viral infection is ruled out. Dexamethasone should also be started within the first dose with the first dose of antibiotics, and it can be used up to 4 hours after starting the antibiotics, and should be continued for 4 days unless the patient is known to be having Listeria monocytogenes, in which case as soon as Listeria is isolated, dexamethasone should be discontinued because in observational studies there was increased risk of mortality in patients with listeriosis who were receiving corticosteroids. Here are the empiric antibiotic choices based on the suspected pathogens. For most adults up to age 50, because strep pneumo and Neisseria meningitis are the suspected pathogens, the preferred empiric regimen includes vancomycin plus a third generation cephalosporin. Most people will use ceftriaxone, and ceftriaxone does not have great CSF penetration, so it should be used at maximal dose. So 2 grams every 12 hours is the dose that should be used for meningitis. Now, ceftriaxone will most likely cover these on its own because there is a small chance that these organisms may be resistant to ceftriaxone. That's why vancomycin is added on top of that to make sure that we get greater coverage because of the increased risk of mortality due to the nature of this infection. For patients aged 50 and older, in addition to covering for strep pneumo and Neisseria meningitis, we should also cover for Listeria monocytogenes. And vancomycin and ceftriaxone are not active against Listeria. Therefore, we add a second, or I should say a third agent to cover Listeria. And this is one of the rare situations where you will have a double beta-lactam on board. In general, we want to avoid double beta-lactam due to increased risk of toxicity such as neurotoxicity, but in this case it is actually the standard of care to combine ampicillin and ceftriaxone. So ceftriaxone will take care of strep pneumo and Neisseria, and ampicillin will take care of Listeria, and of course vancomycin will also be added. Alternative to ceftriaxone is of course cefotaxime, but again most people will use ceftriaxone. The dosing is easier, and ceftriaxone is more readily available in places. In immunosuppressed patients, we also cover salmonella. So the recommendations are vancomycin plus ceftriaxone plus ampicillin. Now immunosuppressed patients are at risk of also having Pseudomonas, but it's not recommended to empirically cover it. If the patient does not improve on this, or if there is indication that there are non-lactose fermenters growing on gram stain, then these can be changed to Cefepime to cover Pseudomonas. And patients with head trauma or post-neurosurgery, they should also cover Pseudomonas. So vancomycin plus cefepime, or vancomycin plus ceftazidime, or vancomycin plus meropenem. So here's what the overall picture looks like. So if somebody has bacterial meningitis, therapy started. If viral infection has not been ruled out, acyclovir will also be started along bacterial meningitis. In this picture, you will also see doxycycline in case there are tick-borne diseases. Doxycycline does not have a role outside of that. And then once empiric therapy is started, if the cultures are negative within 2 to 3 days, we can stop antibiotics if no bacteria were identified. We can also use PCR for rapid diagnostics, and if nothing has been detected on PCR, again, we can stop antibiotics. But if something is detected, we can change empiric antibody to target specific pathogen. For the acyclovir part, if the PCR did not detect any viruses, we can discontinue acyclovir if the suspicion for having a virus is low. Otherwise, even if the PCR is negative and the suspicion for a viral infection is high, we can continue acyclovir until repeat PCR on CSF obtained more than 3 days later. And if the results of the repeat PCR is negative, then we can discontinue acyclovir.